Our speakers today. We just want to give everybody a chance to get connected. So thank you for being with us. Dr. Wallace, perhaps you could ping Dr. Corey?
I just did.
Thank you. And the number of attendees is still steadily climbing. That's great to see. Thanks for joining us today, everyone. So as we're waiting for Dr. Corey to arrive, and we've heard that he's expected momentarily, just as a sort of bit of housekeeping for everyone, as we go through the presentations, if you have any questions, we would love for you to put them in the Q&A window, and we will be monitoring those, all of the questions that are entered there, and we'll be directing them to the appropriate presenter throughout the course of the webinar. We have a lot of time allocated for answering your questions. We've got presentations for about the first hour, a little less than the first hour, and then the entire second hour, nothing but Q&A. So we are expecting to really be able to spend a lot of time addressing your questions. So we look forward to seeing those. And I guess, you know, maybe we'll take advantage of having a few minutes. Oh, Dr. Corey, is that you?
Yeah, that is me. I'm trying to get the video. Okay. Oh, okay.
That's
because
okay.
you stopped it. Okay.
We got you covered.
Okay.
You were
Sorry.
just you were hiding as Beth.
Okay.
You should be able to turn your video on now if you'd like.
All right.
There we go. So by way of introduction, to kick things off today, we have Dr. Larry Corey, who's the principal investigator of the HIV Vaccine Trials Network since it was founded in 1999. He's also one of the past presidents of the Fred Hutch Cancer Research Center. And since last spring, he has been serving as one of the co-principal investigators of the COVID-19 Prevention Network. And Larry, we'll turn it over to you to get us started.
All right. I think you're running the slides, right? Okay. So I'll go quickly here because Allison is really the main event. So let me just say that it's a pleasure to be with you. It's a pleasure to sort of be able to use the resources that we have been allowed to accrue on the area of COVID-19 vaccines. We've had the privilege of sort of being the coordinating center and the privilege of the Hutch faculty largely designing these trials and leading the Army that conducted them. So we'll talk just a little bit about this because the main issue really is what are these vaccines? How did this all happen? And how did we get these wonderful results? And to give you some sense of the science behind it and the basis of the numbers, and frankly, I think to get comfortable with it. Certainly, I've gotten the Pfizer vaccine. I have two daughter-in-laws who are physicians, and they've gotten the Mrna vaccine, and everybody in the family who qualifies will has accepted this, and I think with high enthusiasm. I think it is the way to affect the epidemic, and I think also it's personally, there are many things about it that bring freedom in some ways. So next slide. Everything starts with the virus. Everybody sees this picture. It's on television all the time. Those red coronas, those three things are the trimer. That is what the coronavirus is named for. Next slide. Just to be a little cutesy, the spike protein, the trimer, is how the virus lands on a cell. And it's essentially its landing gear. And if it can't get into a cell and then it can't replicate or go anywhere, in some respects, any virus that doesn't land isn't alive. So knowing where it binds and how to block landing is essential for attacking the agent. And that's where it started, even before we had clinical data. All the vaccines are directed at making antibodies and immune responses to the spike protein. Next slide. This is really pretty good animation, so go with this. The left-hand side is the spike protein. The right-hand side is that pinkish nubbin, and that's the receptor in your nose. There's a hit the button there. You'll see the virus landing on the receptor, and that's a pretty decent schematic. It usually lands like this in an open position and then closes and latches on. And the RNA that's there is to make antibodies to the open structure of the virus. Learn that that's the best way to approach that. That's one of the reasons we have such high efficacy, is sort of learning that painfully through RSV and other coronavirus infections. Next slide. And the vaccine will make antibodies, and you see here they sort of interrupt the virus from landing. And you see that they land on different parts of the spike protein. That'll be important because when we talk about variants and mutations, the vaccine does induce many epitopes, and we are still quite optimistic that the current strains will have quite good protection against the variants that are forthcoming by the virus. Next slide. When we got to start thinking about how to do this, we had a lot of different platforms. Next slide. And they were all being done by big companies, and they were all going to be manufactured in a different way. And we knew that in the end, people were going to compare things. There was no way not to compare a 95% with a 75%. We can talk about that. I think that Allison will talk more about that, but prevention of severe disease is really important issue. And if it's 70% against mild disease and versus 95%, it's really the issue is, does it protect you from dying? Does it protect you from ventilation, et cetera? People are still dying. Two of my friends who are not in the United States, they both are in Zimbabwe. Investigators of long time have passed away yesterday in Zimbabwe from SARS-CoV-2. The way we did this was we would have commonality to the individual trials. They would look alike. They would have similar endpoints. The labs doing the data would be pretty similar. The DSMB monitoring that would be pretty similar. And the statisticians helping design it as well as evaluate it would be consulting and be similar. So in the end, we could make some comparison. And I think Allison is going to go through the Pfizer-Moderna comparison right away. Next slide. And we did this and stacked them up in sort of unprecedented time. The Moderna and Pfizer study started, that's two sort of 30,000 person studies. The Pfizer ended up getting expanded to 42,000 in July, the end of July. Astrazeneca started at the end of August. I think people aware that it was put on hold because there was a an event, a side effect event that occurred in England. System works, everything stopped, actually stopped for a long period of time. And it didn't resume till October, late October, when the FDA and the Data Safety Monitoring Board were, and the investigators were totally happy that the vaccine was safe. And it's gone without an event, and is soon to, it's fully enrolled, and we'll find out about that probably in the next 3 or 4 weeks. Johnson & Johnson study started the end of September, and we expect a readout in the next 7 to 10 days. The Novovac study, the proteins didn't start till December 28th, harder to make proteins than to make a viral vector. That is ongoing and enrolling well. And there's one more in the portfolio, the Sanofi vaccine, that hopefully we'll get to in some way in mid-April. Next slide. The trials were designed to enroll everybody in 8 weeks and get an answer in 7 months. The red line is actually what happened. That we had such an epidemic, we accrued lots of cases, we were very efficient in doing the trials, and the trials ended 2 months early. Now we're paying a little bit of that, because we found out this would work 2 months early, highly work, but the production schedules never really, could be altered that much. And so the reality is that we have our success has precipitated a little bit of the vaccine shortage that we now have. We will, I think, get caught up, but that's part of the reality. Next slide. And I think that is it. I think we get to the real issue of past the design into the vaccines themselves and turn it over to Allison. Dr. Roxby, I should say.
Thank you, Larry. So for everyone, Allison is an infectious disease physician scientist and an associate professor of medicine, global health, epidemiology at the University of Washington. Since the start of the pandemic, she has been involved in outbreak investigation and surveillance in skilled nursing facilities and assisted living settings, and she has brought that expertise to the COVIPN. With her charge has been to fully incorporate older adults into the COVID-19 vaccine research, and she has focused her efforts in 2 main areas: community engagement with older adults and those who work with them, and also providing expert protocol review to allow the fullest inclusion of older adults into the vaccine and monoclonal antibody studies. So Dr. Roxby, we'll turn it over to you to take us through the science.
Thank you so much, Gail. Give me a thumbs up if you can hear me. And thanks so much, Dr. Corey, for the great background and introduction. So pleased to talk to you today about these vaccines. We have 2 amazing vaccines under emergency use authorization. And I use the word amazing, although it's not a very scientific or objective word, but the data I'm going to show is truly striking. And I just want everyone to understand that the research has showed that these vaccines work extremely well. So today I'll be talking about the Pfizer and the Mrna vaccines, which have both been examined by the FDA and are currently approved for use in the US under an emergency use authorization. And both are also being used in other countries around the world. So before I present the data, I just want to underline that both vaccines went through all 3 phases of clinical trials. So clinical trials go through 3 phases. The first phase are very small trials that show whether a vaccine is safe in healthy people. If it passes that phase, then it goes to phase 2, which is a larger study that looks at safety in all types of people and starts to examine whether it generates immune responses. And then phase 3 are efficacy studies, which are large studies to show whether the vaccine works in a large group of people. And then phase 4 is once it's out there, and so we're sort of in phase 4 for both of these studies. So both of the vaccines that we have now in the US underwent the most rigorous testing, which is the phase 3 placebo-controlled randomized blinded trial. And Operation Warp Speed was truly very fast, but it's really important to understand that speed does not mean that there were shortcuts. These trials went fast because they had great funding, because everyone was organized, there was less red tape, the reviews happened promptly, and as soon as phase 1 was done, phase 2 was ready to go, and the same for phase 3. So by being efficient and by having lots of money, we were able to do these trials quickly, but that doesn't mean that there were any shortcuts taken. Next slide, please. So I'm presenting this data from the Pfizer study. This is the figure that was in the New England Journal of Medicine article that's published. And this figure describes what happened to the 2 different groups of participants in the research trial. So this was a very large study. It had 38,000 participants, half of whom received a placebo, which is a saltwater injection, and the other half received the Pfizer vaccine. And what this figure shows is that over time in the vaccine group, they had 9 cases of COVID-19 after full immunization. So after the participants got their full 2 doses, there were 9 cases. And in the group that did not get the vaccine, they had 275 cases over the 4 months that the study was going. So this translates to an overall efficacy of 95%. And I think it's very clear which group you would want to be in if you wanted protection from COVID-19. So this was really a stunning result. It was everything that people hoped for. It was great efficacy and really protection right away after you complete the series of vaccine doses. Next slide, please. The Mrna study published their results just a few weeks later, and you can see a very similar figure here. This study was also large. 28,200 people are represented in this figure. And in the group that received their full COVID-19 immunization, they had 11 cases of COVID-19. And in the group that did not receive the immunization, but had the saltwater placebo, they had 185 cases of COVID-19. And this was following them for 4 months. This resulted in an overall efficacy of 94%. And the added bonus for the Mrna vaccine was that they had no deaths or severe cases in the group of people who received the vaccine. So it was sort of like Christmas came early twice with these results. Both of these results were everything we could have wished for a safe and effective vaccine. And we got the results pretty quickly after the pandemic started. Next slide, please. So both of these vaccines use new technology called an mRNA platform. And there have been so many questions about this type of platform that I wanted to go through briefly how it works. So mRNA is a bit of protein that has instructions for making the spike protein from SARS-CoV-2. So the spike protein are these red spikes on the outer surface of the virus that bind to you and allow the virus to infect your cells. So when the vaccine is injected, this bit of mRNA is in your cell, and in the cell, these instructions are used to make the spike protein. And then your own cell displays the spike protein on the surface and shows it to your body. And as soon as the immune cells in your body see this spike protein, they recognize that it's not supposed to be there. And they create this immune response, which enables you to prevent disease. So that's how the mRNA works. And it's important to recognize that mRNA really doesn't last long in your body. And we know that because we know how difficult it's been to store these vaccines. So these vaccines require storage at ultra cold temperatures, and that's to keep the mRNA from breaking down. So once this mRNA is in your body, it does not last long. It only lasts a brief period of time to enable the cell to make these spike proteins, and then the mRNA is gone. Next slide, please. So while this is a new technology, it's not that new. So scientists have been working on mRNA vaccines for 17 years, and it's because they recognized that it's a great technology for the rapid development of new vaccines. So they've used this technology to make other vaccines for other diseases, including an Ebola vaccine. but these are the first vaccines that have gone all the way to human trials and into an FDA approval. So it's a great technology, and we'll probably be seeing more vaccines using this technology in the future. It's not that new, but it was perfectly timed to be used for the COVID-19 pandemic. Next slide, please. So as Dr. Corey showed, there is research going on other vaccines. We have 7 billion people on Earth who need access to vaccines, and so we are going to need multiple other vaccines that work against COVID-19. So the 3 other major trials that are underway right now in the US include the Astrazeneca vaccine, which uses the chimpanzee adenovirus vector. This vaccine has preliminary evidence that does show efficacy, and we have a fully enrolled trial that's ongoing. This vaccine is also being used in some other countries that have already licensed this technology. The second one is Janssen or Johnson & Johnson vaccine, which is a human adenovirus vector. And this trial is fully enrolled with 45,000 participants. And we are expecting results probably next week for this trial. Very exciting to be having more results soon. And then the Novovac vaccine is a protein vaccine, which is more of a traditional vaccine, sort of like a flu or Shingrix vaccine. And this vaccine trial is enrolling patients right now and started in December. So all 3 of these vaccines look very promising in the early data, and we're hopeful to have clinical data soon that shows that they're working as well. And then there are many other vaccines in development using other technologies. And then there are other countries that have licensed their own vaccines, including Russia, China, and India. And we're seeking additional information about those vaccines. The one place where we're not doing as well as we could is that we don't have enough research right now on young children or adolescents, and none of these trials included pregnant women. Those are some of the areas where we're lacking information. Next slide, please. Okay, so I'm going to go through some common questions and answers that come up. And if you are going to be training or helping educate people about these vaccines, I can assure you that these are the type of questions that keep coming up. So next slide. So the first question that people ask is, were these vaccines tested on people like me? Yes. So the vaccine trials included all types of adults greater than 18 years of age. And in particular, a quarter of the participants had to be over 65 years of age. So all of those trials that are ongoing, and then the 2 trials that were that are under EUA, all included a lot of people over the age of 65. In addition, they had to ensure that they included participants who had common diseases such as high blood pressure, diabetes, HIV, and cancer. So having a medical condition or a usual medical problem did not keep people from participating in the vaccine research. And similarly, people could participate whether they were taking medications or had other health problems. The only types of conditions that were really excluded was people using heavy immunosuppressing drugs, and that included sort of current ongoing cancer treatment. But there were a variety of participants who had many different common health problems and took many medications, and they were all included in the research trials. The big exception, again, was that the vaccine studies did not include pregnant people. Next slide. Another question that's been coming up based on some rumors going around and some sort of different interpretations of research is, do these vaccines work for people of different races or ethnic groups? Basically people with different genetic backgrounds. So yes, there are some small biological and genetic differences in the immune systems of people of different backgrounds. And if you do laboratory analyses, you can see some of these small differences. And so sometimes we see different immune responses among different people with different genes. But regardless of that, there's strong evidence that the vaccines work well for all people, regardless of their genetic background. And diverse racial and ethnic backgrounds were included in the trial and were part of the strategy for testing these vaccines in large groups of people. Next slide. What types of reactions have been reported after vaccination? So it's very common to have reaction after vaccination, and I would say that we should tell people to expect some of the common reactions. So having a sore arm, getting a headache, having some body aches, or even having a fever are commonly reported reactions in the first 1 to 2 days after receiving vaccination. And this was reported with both the Pfizer and the Mrna vaccine. These are similar to reactions that people experience after other vaccines, such as the shingles vaccine or influenza vaccines. So these are common, and the data from the research trials showed that people experienced this and then it went away. There were also rare reactions, and we actually have good post-marketing data on this right now. So there have been cases of anaphylaxis, which I think you all have heard about. Interestingly, we didn't have any cases in the research trial. So the Pfizer vaccine showed 21 cases after the first 2 million doses delivered, and the Mrna vaccine had 10 cases of anaphylaxis after the first 4 million doses delivered. So none of these reactions were fatal. They were all managed with medication, and everyone had a complete recovery. The current recommendation is for all persons who get this vaccine to have a 15-minute period of observation after the injection. In addition, anyone who has a history of allergies or anaphylaxis, it is recommended discussing this with a provider and then having 30 minutes of observation after receiving the vaccine. And all of the providers who are giving vaccine are required right now to have the ability to handle an anaphylactic reaction. But it's important to emphasize that although these reactions have occurred, they're rare, and most people who have a history of allergies or anaphylaxis, so people with a peanut allergy or people with a medication allergy, have received these vaccines with no issues. So rare but serious reactions. Next slide. Another common question that people ask is, should I get the vaccine now or should I wait and see? So this is the concern that this is something new and don't want to go first. So maybe I just want to hang back and wait. Well, at this point, 21 million Americans have gotten these vaccines and over 60 million people have received them worldwide. So I would say if you're worried about going first, you're not the first person right now. In fact, many millions of people have received these vaccines. In the United States, we have the CDC, which is monitoring safety, and they've been doing a very good and communicative job of this. So the reason we have all that data about anaphylaxis is because the CDC has been actively collecting it and then telling us what they're finding. So the V-Safe is a personal method of monitoring any side effects that you're having, and then VAERS is what doctors and nurses can use to input any severe adverse events. So both of these mechanisms are up and running and actively looking for any problems with vaccine. Another argument against waiting is that right now we basically have the worst COVID-19 epidemic that we've had since it started. In the United States, we're having almost 20,000 deaths a week. Cases have been rising. And so now is the time to get a vaccine because now a person's risk is highest of getting COVID-19. And the vaccines take 4 to 5 weeks to protect you fully. You're not considered fully protected until 1 week after your second dose. So with the pandemic raging and it's going to take 5 weeks to get protected, I personally would not recommend that people wait. I think now is the time to get it for the most benefit. And then finally, we've been talking about the new COVID-19 strains that are more contagious. So again, all the more reason to get immunized now so that you're protected if and when we're dealing with these more contagious COVID-19 strains. Next slide. So does mRNA change your DNA? We talked about this briefly, but just to remind everyone and to make sure that we're able to tell others that no, it does not. So mRNA stays in the outer part of the cell. It doesn't enter the nucleus where DNA is located, and it doesn't stay in your body for any significant length of time. So it never contacts your DNA. It leaves your body quickly. And just like other vaccines, the material is really in your body for a brief period of time, just for a couple of days. So there's no evidence that it can change your DNA. Next slide. Why do I have to wear a mask after being immunized against COVID-19? Great question. Everyone is upset with this recommendation, but the vaccines right now, we know that they prevent severe disease and they prevent death. There are still some people who get COVID-19 despite being immunized. We saw that those very small numbers of cases, 9 and 11 people, which is why it's 95% effective and not 100% effective. So you can still, rare, but you could get COVID-19 after immunization. But more importantly, we don't know if the vaccines prevent asymptomatic infection. This was not studied in the 2 trials that I showed you. So you might be protected against dying or getting very sick from COVID-19, but it might still be in your nose where you could spread it to another person. And right now, not many people have been immunized. So until we have less COVID-19 in the community and until we have more knowledge about how the vaccines work, we have to assume that vaccinated people could get COVID-19 and not know it. So the current recommendation to continue wearing a mask, social distancing, hand washing, we're going to be continuing all that until the pandemic is under much better control. Next slide. Is 1 dose of vaccine as effective as 2? I wish it were, but it's not. So the data are very clear from the Pfizer and Moderna vaccines that the best protection happens after the 2nd dose. The first dose starts your immune response, and then the 2nd dose boosts it to give you higher antibody levels. So really, you need the full 2 doses to get the most benefit. If your 2nd dose doesn't happen on the exact day, 21 or 28 days after your 1st dose, that's okay. If a little more time goes by, that's okay. You'll still mount that great immune response, but you do need the 2nd dose to get the best protection. So unfortunately, we're not going to be able to fudge this. It's definitely true that 2 doses are better than 1. Next slide. How long does vaccine immunity to COVID-19 last? We don't know. This is a brand new disease. It's a brand new vaccine. There's a lot going on. We need more time to figure this out. So for now, we just need to help people get immunized, and we'll have to check in with that when we have a bit more knowledge. Similarly, how will viral mutations affect COVID-19 vaccines? Well, the truth is we don't know. And the truth is that there are many viral mutations. So this was always a possibility, and scientists are actively working to study this, not just for the mutations that you've heard about on the news, but for other mutations that are also out there. So right now, it looks like we're in great shape. We have a vaccine that works great and that binds the most important part of the COVID virus, which is the spike protein. So right now we're in great shape, and I think everyone should just take the vaccines that we have, but we will need to get additional information about this. And of course, we're very humble in the face of COVID-19. So far so good, but yes, we'll need a lot more knowledge about this going forward. Next slide. Okay, great. That's the end of my slides. I see some Q&A, but I think most of this, I'll just answer. Gail, can I answer one of them?
Yeah, absolutely, please.
Okay, there's a question that says, was the recruitment for trials for ethnic minority populations, particularly Black, Indigenous, and people of color, the same as whites? That's a great question. I would say that these trials had an incredible focus on making sure that there was adequate enrollment of ethnic minority and BIPOC populations in the trials. It was something that was talked about every single week, and it was something that people with special expertise in this area addressed. Gail, do you want to add anything to that?
No, that's a great, and I think the other question I was going to direct to you is from Bethany, who asked, when will we know whether the vaccines actually can prevent infection and transmission in addition to disease?
That's a great question. I am not sure when we will have the answer to that. I know more people are interested in looking at this, and there is research underway now. So I would say give us 2 to 4 months, and then some of the clinical trials express this a little bit differently. So we may have additional information.
Great. I think we'll save the rest of the questions for a little later in our time together. Thank you so much, Dr. Roxby. And we'll move ahead now to looking a little bit at the idea of how we engage the communities, kind of along the lines of that first question that we heard. And we'll be hearing from Sally Bach, who is the Senior Director of Marketing for the CoVPN. She's been working on branding and marketing campaigns for a range of organizations, everything from Fortune 500 companies to small nonprofits. And she is one of the people that helped to create the Give Big campaign in Seattle, which some of us I'm sure are familiar with. She's also worked on some national initiatives focused on health disparities, in particular for the Robert Wood Johnson Foundation and the W.K. Kellogg Foundation. So Sally, we'll turn it to you to tell us about tools and materials.
Thanks, Gail. Yeah, so great presentations from Drs. Roxby and Corey, and a lot of information to take in. I imagine that many of you joined because you are in a position of needing to communicate this kind of information. And so what I want to do is give you a little bit of background and access to some tools that will hopefully make it easier for you to do that. And I can see from the questions we're going to have a lot of great conversation about what was presented from a scientific perspective. Before we start looking at the tools, I just wanted to share with you a snapshot of where American public opinion is right now in terms of people's intention for getting the vaccine. You may have heard Dr. Fauci quoted recently saying we need between 70 and 80% of people to be vaccinated. So in this survey, this was American adults over 18 just last month, we saw that about 30% are at a point of saying they are intending to get a COVID-19 vaccine, and a much larger group are either open but uncertain, or they are skeptical, or they are quite resistant. And we're looking at that middle section as a movable group, but they're right now in what Allison described as the wait and see group. So they have questions they want answered, they want a greater degree of comfort from their own providers, or they want to see how it goes for other people. And so, next slide, please, Michael. When we break down that group and say, well, where are those who are intending and where are those who are at various stages of confidence in the decision to get the vaccine, we see that within Black, Hispanic, and the younger segments is where we see the smaller groups of people who are intending to get the vaccine or who have questions or who are resistant to the idea of getting that. So I think that's helpful when you're opening the conversations or having conversations with people, understanding the majority of people really have questions that they want answered or information that they've received that is causing them to feel uncomfortable. And if we look at the next slide, we can kind of categorize what makes up that hesitancy. So the first is questions and concerns about benefits, safety, and side effects. These are new vaccines that are just starting to be rolled out. So people really want to understand more about them to be able to do a sort of cost benefit, risk benefit analysis for themselves and decide if it makes sense. This was done very quickly. And so there's a lot of concern about were corners cut? Is there enough data? Were people like me, whatever that means, my set of concerns in the study already? So can I trust that the things I'm worried about have been looked at. There's distrust in terms of the political or economic motivations of those that were involved in the development of the vaccine, whether it was specifically around this or it comes from historical or current experiences of systemic racism or being cut out of access to healthcare, et cetera. And then the fourth is both the established, so sort of ongoing misperceptions or conspiracy theories that exist about vaccines, which have gone back centuries actually, or novel ones that are specific to COVID-19. So we've seen some new ones come up in the cultural conversation, whether it's being injected with microchips or infertility or other concerns that are circulating in the community conversation. So what do we do to address these reasons for vaccine hesitancy? Our approach has really been to have open, transparent conversation, to give people facts that they can evaluate and they can balance against the things that they're hearing. And to also be very transparent about what we don't know. So not over-promising where we don't have data yet, but just making sure people really have the information so that they can make their own decision. So next slide, please, Michael. So we have been creating quite a breadth of content based on what we know are the questions and needs that people have, and also what we know are relatable, accessible presentations of that content. So we have quite a deep community engagement group that looks at our content, gives us feedback as we're developing it, so that we are making sure that those people who are going to be reading it and receiving it, that it's meaningful to them, that we're giving them as much information as they want, but not too much. And also that we are presenting it in a way that is very respectful of the questions that they have, and using spokespeople that we know are trusted by them. So if you look at the top, you'll see this tiny URL, and that tinyurl.com COVID-19 materials, where you can go and download any of the materials that we've created. There are documents, there are infographics, there are videos, there are animations. There are short little Q&As that are Ask an Expert that are between 30 and 2 minutes of answers to commonly asked questions. And we just encourage you in whatever your channels of communication are to feel free to use these, to distribute them, to put them on social media. And we've tried to lay them out in a way that's really easy for you to access and to navigate. So in that Dropbox, you'll find categories of the sort of material type, and then you'll find the actual assets. So for example, some of the videos that we've created for social media, you might decide that you're going to drop in a PowerPoint instead. It's perfectly fine. It's just the aspect ratio is set up for social media. So I thought I'd share a couple of pieces. One is an animation of what mRNA vaccines are. It's about 1.5 minutes, and it's a summary, another summary of what Allison presented.
What is an mRNA vaccine and how does it work? Both Pfizer and Moderna are messenger RNA vaccines. They teach your body how to recognize the virus and fight back. What happens when you're infected with coronavirus? Viruses can't replicate on their own. To multiply, they attach to host cells and use them to make copies of themselves. The new coronavirus does this by attaching to a healthy cell using the spiky proteins on its surface. Once inside, the virus takes command of the cell's machinery and starts making copies of itself that can attack other cells in your body. To fight the infection, the body makes an immune response specific to the virus. These antibodies and fighter cells attach to the virus and allow the body to clear it out. What do the mRNA vaccines do? These vaccines get the virus's genetic information to your immune system before you are infected, so that if you do come in contact with the real virus, your body already knows how to fight back. How? The vaccine uses the genetic code for the spike protein on the surface of the virus. The vaccine carries it with a message that teaches the body to make the protein itself. It's like showing your body the recipe for making spike protein. When injected into healthy muscle cells, the mRNA instructs them to start making the spike protein. The immune system sees this spike protein and responds by making an immune response. The immune system will remember the spike protein and, if it sees it in the future, it is ready to respond.
Thanks, Michael. If we can go back to the slides. Just want to share with you also some of the infographics that we have. So here are some examples of some infographics that take some of the most pertinent information that people are asking for and put it in some very simple visual formats. And if we go to the next slide, just zoom in on one of them. So this is what did the COVID vaccines do? And this is both laying out what is it that we know about them, and then what is it that we don't know. So we've been talking a little bit in the chat about transmissibility and when that's going to be known. So just underlining the fact that unfortunately, until we know what its impact is on transmissibility, we need to continue to do all of the safety behaviors that we have been doing. So thank you all very much. There's, I will put the tiny URL also into the chat so you have it. And I really want to encourage you to keep your eye on it. Right now, there's quite a robust group of materials in English and Spanish, and we will continue to be expanding them. So we're creating new content every week. So please do keep checking back if there are questions your community is looking for answers for. Pretty likely we are getting those questions too, and I'm working on content to help address some of those questions and concerns.
Great, thank you, Sally. And just to underscore again that tiny URL for the Dropbox folder, and we'll get that in the chat for you. Those are all materials that you are welcome to access and you are welcome to use. We have put them there for you, so you should feel free to take a look and use anything that you find. So we wanted to just before we move into the panel, we'll take just a few questions just to really clarify and make sure that the science is clear. And I see a sort of a set of questions that I think are all connected, which is really and I'll invite Allison or perhaps Dr. Ingman, who hasn't been introduced yet either, but we've got questions about the people that were not included in the studies. So if any of you could share, what are the plans for doing studies around the safety for pregnant persons, around people who had severe allergies? I'm looking to see if I've missed any. I think those are the two big groups. If any of you could speak to how are we going to learn more about that?
So this is Allison Roxby. I'll talk about pregnant people. So at the moment, what the FDA has said is that the risks of being pregnant and having COVID-19 are considerable. And the risks from vaccination, if you're pregnant are thought to be small. So at the moment, pregnant people are encouraged to get vaccine after a discussion with their provider. And then there are multiple observational studies going on to sort of follow those people and see what happens to them and their babies. And I know that the CDC VSafe app, which is an app that you can sign up to participate in after vaccination that asks you about your vaccine experience, has been flagging pregnant people for additional questions to check in with them. So that's what the plan is for pregnant people right now for immunization.
Awesome. And I know that in regard to allergies, we've been seeing guidance from the CDC that says that if you are somebody who knows that you have a history of allergies, and perhaps you're someone who carries an EpiPen with you, that they want to make sure that you're speaking to your own provider first, and that it may very well be appropriate for you to get the vaccine. What they've been doing is having you alert the staff at the vaccination center to make them aware that you are someone with allergies. Typically, then they will monitor you for an extra period of time to make sure that you're safe, and that they would make sure that there are emergency supplies immediately on hand should the need arise. But people, as Allison's slides presented, there have actually only been a very small number of cases of these severe allergic reactions. Our colleagues at the National Institutes of Health are also putting together a study to more closely follow people who have a history of allergic reactions. We don't have details about it yet because it's a study that's still being written, and it's not yet final, it's not enrolling yet. So we'll have to sort of stay tuned to learn more about what that study has to tell us as it gets finalized going forward. The other question, Allison, that I think I can direct to you is, again, kind of following up on some of the details about distinguishing between disease and infection. And we had one question about, will it be safe for my family and I, including a small child, to visit my parents who are both elderly and immune compromised once they have been vaccinated? Is it safe for them? Is it safe for us? Do we need to wait till everybody's vaccinated? Masks on, masks off? And then Jennifer also added to that with, it's a little bit unclear if the part of the function of the vaccine is purely to protect me, or is it also to protect others?
Those are great questions, and I think that we all actually have a lot of knowledge about this from our experience with other vaccines. So I'll first start the question about how do we protect others. So if you're thinking about visiting a family member who may have been vaccinated, so the thoughts that go through my mind, because I'm also in that situation, is first of all, the vaccine is not 100%. So is this a person who really needs to be protected because I'm going to be traveling through through a raging pandemic to visit this person? So that has to be factored in. And that risk calculus is going to be different than if you were traveling and there was no disease that you were passing through. And that would be the same, if it was a very bad flu pandemic and you were going to visit somebody after having had the flu vaccine, you probably would be wondering, well, is this really going to be enough protection? So I think when you're talking about immunocompromised people or vulnerable people, you have to look at the state of the entire pandemic, as well as your own personal state of protection and the protection of the person who's been vaccinated. Right now, we have a raging pandemic, so the vaccines can only do so much. And we're trying to get to that point where things are looking better for the entire pandemic. With regard to the question of, are we doing this to protect ourselves? Are we doing it to protect others? The answer to that, like with all vaccines, is yes. we're doing it for both reasons. The primary protection is going to be for ourselves, but we know that when lots of people are vaccinated, that enables us to protect our community as well. It reduces community spread and transmission. We're a long way from getting to that point with COVID-19 where we're going to feel like we have that immunity of our community, which some people call herd immunity. But everyone who gets vaccinated contributes to that pool. So it's not very satisfying because it's early days, but I think in a few months, we'll all be feeling much better about the situation that we're in.
Absolutely. I think for the rest of the questions that I'm seeing, we should move to our panelists. So let me introduce the rest of the group. We are joined now by my manager, who I just have to say that because I love her and I love that she's my manager, Dr. Michelle Andrasek, who is a clinical health psychologist. She is the Director of Social Behavioral Sciences and Community Engagement at the Fred Hutch for the both the HIV Vaccine Trials Network and the COVID-19 Prevention Network. And she's also a senior staff scientist for the Fred Hutch and an associate clinical professor in the departments of global health and occupational and environmental medicine at UW. We are joined also by Dr. Stefan Wallace, my teammate and dear friend, who is an expert in developing, implementing, and evaluating major public health and human service programs in the areas of prevention, care, and treatment of HIV and AIDS, as well as other infectious diseases. He is our Director of External Relations for the HVTN and the COVID-19 Prevention Network. And Dr. Wallace has really, he has more than 2 decades of experience working in sexual and public health, social justice, and community mobilization. We're also joined by 2 very distinguished gentlemen from outside our Fred Hutch circle. We're joined by Dr. Cyril Engman, a clinical professor of global health and a clinical professor of pediatrics and neonatology. He also works as the global program leader for maternal, newborn, child health and nutrition at PATH here in Seattle. Dr. Engman is directing the work of more than 120 staff working in the US, Asia, Africa, and Latin America. Prior to joining the team at PATH, he was part of the Bill and Melinda Gates Foundation's newborn health strategy, and he remains an active physician and practicing academic. He's on the faculty at the University of Washington. His accolades go on and on. These are very distinguished folks indeed. And last but certainly not least, Adrian Dominguez joins us. He is the Director of Informatics and Epidemiology for the Urban Indian Health Institute. He received his Master of Science in Epidemiology and Biostatistics from the School of Public Health at UCLA. He has been awarded the Harvard University Health Professionals Fellowship and attended Harvard to study neurology and public health. And he has over 23 years of experience working as an epidemiologist. His work has included pediatric lead poisoning in low-income areas, work in HIV/AIDS, maternal and child health, diabetes, breast and cervical cancers. I could go on and on. We're so fortunate to have this expert panel with us to help field these questions. And I'll start by, I think we've got everybody on camera. All right. I'll put this out to the group because I think it could probably be answered from a number of different points of view. We had a question from someone who teaches and has units being presented to middle, elementary, and high schoolers, and they all want to know, when can school reopen and when will it be safe? When might we see vaccines for young people and children? How will we know when it's time to go back to school? Anybody want to dive into that one? Everybody's being timid. Go ahead, Allison. I saw you wave.
Yeah, so I answered a similar question in the chat. So there are 2 trials happening right now for ages 12 to 18 for Moderna and 12 to 16 for Pfizer. And so those will have results reasonably soon for those trials. They're not as large as the adult trials because some degree of efficacy is likely to be presumed. So for 12 and above, I think we'll have results in a couple months. For under 12, I've heard lots of planning discussions, and the plan is that there will be a pediatric vaccine or many pediatric vaccines. I don't believe those trials have started yet, but I think that we're looking at a slightly longer timeline. Hopefully those trials will start in the next 6 months.
Yeah, typically it's kind of a stepwise. We sort of keep ratcheting the age limits down a couple of years at a time so that we can proceed in a really safe manner. So I've also heard that the goal is really to be able to get teachers vaccinated by the end of the summer so that theoretically we might be able to see students going back to classrooms in the fall for the next school year. And I see Dr. Engman nodding. Dr. Engman, do you want to add to that at all?
Oh, thank you for a lovely introduction, by the way. And no, I agree with that. I think, once we're at a place where our teachers are better protected and vaccinated, we'd be in a better position to have most kids go back to school.
Great. There was one question in the chat and I saw Michelle. No, actually, Michelle answered a different one. So let me scroll back up to it here. And I would put it out. I know, Michelle, I'm looking to you in particular because I know this is the focus of much of your research. Do you think that racism, medical experimentation, and historical trauma has a role in vaccine hesitancy?
Yeah, well, I think that, there's irrefutable evidence that it has a very large role in vaccine hesitancy. And I think one of the points that it's critical to make is that it's not just historical trauma, it is everyday experiences of racism and discrimination that also create hesitancy, vaccine hesitancy to engage with the larger medical infrastructure generally. And one of the things I wrote in the chat, which I think is really critical, is that, Dr. Wallace, Dr. Roxby, Adrian, Dr. Ingman, and many of the panelists that have been engaged in some of our webinars and our listening sessions, answer these questions directly. And I think it's really critical when community members bring these points up that we not only acknowledge them, but have open and honest conversations about what concerns and what fears individuals have based on the history of this country.
Yeah, definitely. I'm curious to hear, Adrian, please. I was just going to call on you and ask if you could add to that.
I think, to echo what Michelle has said, I think it's really important that we listen to that. I think that's like one of the top points that always comes up with communities of colors, at least the communities that I've been working with, is expressing concerns about that. And not only on historical trauma, and we have evidence just with the last administration on forced sterilization of women. And so we really, really need to listen to that. Many of the individuals that I speak with or interview also think that they are going to be in an experiment, and sometimes thinking that they are not going to be given anything in the event that they get sick. And so it's a real issue, that this is something that needs to be addressed. It needs to be listened to, and I don't think that part of like trying to get people vaccinated, unless we actually address this and listen to this, you're still going to see this as being a problem, particularly with people of color.
Thank you. Please, Dr. Ingman.
Yeah, I'd just like to add to that. I agree with both Michelle and Adrian. Unquestionably, the history of what has happened and continues to happen to all people, to many people, actually, I'd say virtually all people of color especially, makes them naturally suspicious, right? And certain comments that were made in the previous administration didn't help the situation at all. That said, as a scientist and as a physician and as someone of color, and as someone who was privileged to look at the trials and to look at the results and to look at the way in which they were crafted, I felt confident by the end that any misgivings I had been addressed. And I felt confident enough to, as a frontline worker who works in the ICU as well, go and have 2 vaccines. I just completed my 2nd shot yesterday, actually. So if that's of any help, over.
Terrific. I see there's a question in the Q&A that Sally noted that she'd love to answer. Are there any efforts to develop outreach materials from trusted leaders in Black, Indigenous, and other communities of color, such as video promos or other easily accessible modes for people who might have limited English proficiency or to address some of the vaccine hesitancy? So Sally, please tell us about materials.
Yes, I'm delighted to say that there are many, particularly video assets. One of the things we learned is that doctors and nurses, but especially doctors, are really a trusted source of information on the vaccines, and particularly doctors from the Black, Latino, Indigenous communities, because people feel that they have their interests in mind. And so we have quite a few quick snippets, Q&A questions that are answered by video of our experts around the country in Spanish and English, and representing different communities. So please go check them out. We also have Dr. Fauci, because he tested well, and addressing particular communities. We'll right now have excerpts from a conversation he had with the Black community, and we're in the process of editing a set of questions from conversation he had with the American Indian, Native Alaskan community. So those exist and more will be coming.
Terrific. And we should note that the materials in the Dropbox are available in Spanish as well as English. Some of the items are also available in Portuguese. If you have needs, I think I saw Michelle noted that King County Public Health is working on some Asian and African languages as well. So if there are other languages that you, please, Adrian, I saw your hand.
Yeah, I'm just going to throw out a plug for my organization, Urban Indian Health Institute, uihi.org. We have quite a few, over 25 resources specific to American Indian, Alaskan Native, with Indigenous images on it, and that are culturally attuned. So I'm just throwing that out as well.
Excellent, love it. So I think this next question perhaps is for Dr. Wallace. We heard earlier from Allison about the involvement of communities of color who were participants in the studies. Can you talk about what are some of the successful strategies that the CoVPN has used to meaningfully engage racial and ethnic minority communities?
Sure. Many of those strategies, I think, fortunately, we've sort of leveraged and borrowed from our HIV work. And that includes the development of a community working group that I think was also referenced here. And this group was made up of community members who are staff members of our clinical research sites, as well as community advisory board members and advocates who are not organically connected to our research sites. We also developed expert panels. Michelle really helped to lead that process, and that involved actually Adrian and Dr. Ingman as well. And so there was a need to ensure that there was expert representation from diverse communities, particularly from scientists who have expertise in these communities and who are also members of these communities, to review the protocols and provide reports about ethical considerations, implementation considerations. In addition to our work with community partners, we have strong relationships with community groups across the board and have worked to develop and enhance relationships. We have a massive faith initiative that is working nationally to engage faith leaders across different faith and theological frameworks. And I feel like I may be missing some because there's so many. But there are lots of efforts and ways that communities have been meaningfully engaged in this process. And this is what I describe as sort of at the national or network level. And certainly, we've also done a lot of work at the community and at the site level to meaningfully engage communities to be a part of processes as well. So.
Great, thank you. And Sally,
can I just add something to that? I think it's really critical also to point out that people like Adrian and some of our expert panelists, Bonnie Duran and Karina Walters, have been really critical in reaching American Indian, Alaska Native folks, really educating all of us on the importance of data sovereignty and data ownership, and really bridging connections between researchers and tribal leaders to ensure that the needs of the tribal communities were met for these research protocols. And that has really resulted here locally, actually, in a lot of American Indian and Alaska Native participation in some of the later trials. So kudos to that effort. I mean, that is really an unprecedented effort.
Absolutely, absolutely. And I was going to ask Sally if you could say a little more, because one of the things that your team really worked on was making sure that we were advertising and being visible in the right kinds of places. Could you talk about that effort a little bit?
Yeah, absolutely. So when we started the advertising and marketing outreach, we started with insights from our priority populations, which were Black adults, Latinx adults, and Indigenous American Indian adults, and created materials that spoke specifically to what we heard from them versus what often happens with just a sort of general population campaign is created, and then, you know, it's tweaked for those particular audiences as a sort of second thought. We started with them as our primary set of insights. And then in the insights that we gained, we also learned from there, where do they like to get this information, and where and from whom, and how do they like to receive it. And so we then put together a media plan that really focused on the places that they go to for information. So whether there's a group that often leans on Google as a place to do their own research, and other people really value content that's shared by trusted people in social media. So that was a big part of our strategy. But then also being on the channels and media outlets where our community is spending time.
Fabulous, thank you. Dr. Engman, I think you might be best positioned to answer this question as a practicing physician, or Allison, you should feel free to jump in as well. How do you personally encourage people to get the COVID vaccine, especially if there's someone who refuses to get a flu shot?
That's a great question. Can you hear me now?
Yes.
Yeah, that's a great question. And I come across a bunch of people who refuse to have shots of all kinds for themselves, and then also refuse to have their kids have shots of all kinds. And I think, you know, there are probably three important principles for me. One is to really actively listen and understand where they're coming from, right? Everyone has a story, and it's the worst thing I can do is to discount that. And to my knowledge, the best thing I can do is to really actively listen, and then look for somewhere where I can validate, even if it's just how they felt about an episode, not necessarily about a vaccine or something else. So one is active listening and validation. The second, for me, is to share information honestly and transparently. And I think Alison had already talked about that. There's everything to be gained in being completely transparent, and everything to be lost in trying to overpromise, underpromise, overstate, understate. And so being really careful so that I am presenting facts as I understand them, as I know them, and encouraging them to the best of their ability to look at that as well. And then the third bit for me is sort of helping to imagine a world where they have had the vaccine, especially compared to a time when they didn't. And it could just be the flu vaccine in this particular case, but it could be many other vaccines where one of the big challenges in public health is that as you help to eradicate or minimize or mitigate or decrease the incidence of something, one of the big challenges in public health is people forget what a big problem it was, and then sort of buy into the whole notion of some conspiracy theories and various other things. So I think to me, it's more about once we get to a place where there's information, so I validated what they've said, I've listened actively, I've been able to share information and have a very honest conversation, to then look at this world where we say, this is where we were and this is where we could be. And now they have the information. So now they are at a position where they're actually empowered to make what actually often turns out to be the right decision. That's perhaps my perspective. Alison, you might have a different perspective as well.
Oh, thank you so much, Dr. Engman, for those comments. I agree, listen. And then we also have to remember that it's not a one-shot deal, right? So the person may decide they're not getting immunized today, but they may feel deeply heard and respected. They may come back to you later with more questions, and you may get another opportunity in the coming weeks or months. Whereas if you shut them down or dismiss their concerns, or mock them for where they're getting their information, then that door will be closed and you won't have that opportunity in the future. So I think looking at it as it's not a zero-sum game. This is building the relationship that you want to be building and sharing the information. And when they know that they can ask you those hard questions and get a straight answer, that's when you'll start to make progress.
Absolutely. There is a question, and I wish that I knew how to pronounce this individual's name. So the person whose last name is Kone, I'm going to guess that's Kone or Kone. And I don't want to mispronounce your first name. I apologize. This individual asks, so that while we're pleased that BIPOC communities were considered in the studies, this person feels that we also need to state that there may be things that we don't yet know about these vaccines, and it may not be 100% risk-free. So how do you suggest communicating, and I'll put this out to the panel because I know that all of us in our different roles come across this. How do you communicate that nothing is risk-free and that perhaps the benefits outweigh the risks?
I think that's a great question. And hi, Awa. So great to see your name.
Now I know how to say it. Thank you.
Really great to see your name in the chat. So one of the things that I've seen a lot of individuals do really well is to engage individuals in a risk-benefit analysis. I mean, if you look at the disproportionate impact of COVID on BIPOC communities, if you do get COVID and you do have a pre-existing condition and you are over 65, weigh your chances of hospitalization and death as compared to the small and relatively minor side effects that we are seeing in both of the vaccines. And I know, for people who are incredibly vaccine hesitant, that's not, a trivial conversation. I think we really have to look at the impact for ourselves, for our families, and for our larger communities. And, I'll say, as Dr. Ingman has said, as soon as the vaccine is available for me as a Black woman, I will get it. I will get it. I will get my second dose. I think not only for myself, but for my family and for the larger community, because I think that without effective interventions, we will continue to see the disproportionate impact on our communities. We will continue to see the disproportionate hospitalizations. We will continue to see the disproportionate deaths. We will continue to see families struggling with job loss and missed work, and children and not in school. And I think that the impact on our communities has been so incredible that we need interventions, and we have 2 viable interventions now. And the side effects that we're seeing are so minimal. And it's true, we don't know long-term impact, but we also do know some long-term impacts, because people have been taking these vaccines for, since when they start in
November.
June?
Or the studies
Yeah,
were in
the studies.
July,
The first injections were in June of last year.
April,
So, or April, yeah. So we do have some long-term. Now, I know long-term for a lot of people is not since April, so I get that. And we will still be studying it. But for me now, everything that I know about these vaccines, which is a lot, does not give me any pause to take them as soon as my turn comes.
absolutely. Please. Dr. Wallace, go ahead. And then Allison will come to you next.
I will also add, and I agree with everything that's been said. I will add that I think the risk benefit analysis is really an important conversation, and it's something to really communicate that this is something that people need to sort of think about for themselves, right? And as they're weighing that, I think it's also important to consider the impact of actually getting severe illness associated with COVID-19, right? And so you're talking about people being put on a ventilator, and also people potentially having access to EUA treatment medications, right? That also have not been, that haven't been studied for a very long amount of time either. So we have EUA sort of on both sides, right? On the prevention side, as well as on the treatment side. The other thing is where are people in this process of practicing the recommended guidelines? If people are, relatively at lower risk, they stay at home, they don't live with people, they don't have, they don't go out and interact with people very much. So I think it's really about where do people sort of fall in this process and how they evaluate what this looks like for them, and being really clear that this is not something that other people can decide for you. You really have to decide this for yourself, and that the hope is that you have enough information to do that.
Great. And then Allison, I think you wanted to add as well.
Yeah, I just wanted to share some strategies that I think have been working for me. I try not to put the burden of the entire pandemic on one person's shoulders. So I try to avoid that, we're never going to get out of this if you don't do this vaccine, because I feel like that's hard. That's a hard position to be in. But I do think from a physician's perspective, when we look at adverse events from vaccines, they all happen in the short term. So mild, moderate, and severe adverse events are all relatively short term around the time of vaccine. So even the most terrible things that have ever been described from vaccines, things like Guillain-Barré syndrome, they happen in the 1 to 3 weeks following a vaccine. We don't really have a historical record of multi-year long-term side effects from vaccination, other than the multi-year benefits that accrue. So from a physician's perspective, I don't think there is a lot to be concerned about multi-year long-term adverse events. And I would ask patients to think about their experience with other vaccines where we really don't I mean, people don't come to me with a headache and I say, well, maybe 5 years ago you got a flu vaccine and this could be related. So long-term side effects are really not a thing with vaccines. And I think we need to decrease the expectation that we're going to discover some as time goes on. I don't think we will. And then the second thing I wanted to say, and this goes back to a different thread that we're talking about, which is about myths on social media. I try to ask people really to think about people they know and trust and where they want to get their information. So, I'm asking people to say, a random person on the internet said something, but I'm sitting here with you now and you and I know each other and we've been working together and we have that trust built up. So I feel like when you make decisions about your health, you need to look to your trusted people. And that's what's so great about everyone on this call is that you make up that community of trusted people who can communicate that with our patients.
Absolutely. Great answers. Please, Adrian, go ahead.
Can I just add something to what everyone else is saying? So for our experience, and I think that this is really important, I think, especially with people of color, like the Latinx population and also the American Indian Alaska Native population, I think it's important for them to see that people like them, that look like them, are getting the vaccination. And that everything's okay. Maybe they have a slight reaction, because those are trusted individuals for them to see those individuals. And I think it's important that we show that data to people of color, that those populations are also being vaccinated, and one of the conversations that we continually have with the American Indian Alaska Native population, and this is just something to take into consideration and you have to discuss it. And that is, there's a cultural component here. There could be a loss of the culture, the language, as if we see like older populations passing away, right? And so that has come up a lot for us in when we're just talking about hesitancy. Some individuals, we ask them like, why are they hesitant? And items come up about speaking that some things will get lost. And so that might be a way to open up for somebody to get vaccinated, right? And so I'm just throwing that out there. There's different things that you can discuss that are really important to individuals and those populations, that will give you an opportunity to maybe offer like, here's something that you can do so those things don't get lost.
Absolutely. Yeah. The value of respecting that cultural heritage and those meaningful motivators. Yes. Had a great question from Robin about how do we best reach the small populations that have high COVID incidence, such as immigrants from smaller countries who may be more invisible, people who are incarcerated, sex workers, the homeless. I was just on a call this morning with the outreach workers of the Los Angeles County Homeless Services Association. So we were talking about this, but I'm curious to hear from our panelists. How do you suggest that we best reach these smaller groups that have high incidence?
I think community vaccination sites, something that we've been talking about and working on diligently here at Fred Hutch, and sort of to pair back to a comment Allison made about trusted voices and ensuring that we're working with communities and establishing community vaccination sites to reach these communities, particularly community organizations and groups that already have relationships and inroads, that already have the trust of these communities. And these are the places that these communities would go to naturally for services or for support and for resources. So I think that that's definitely one strategy to reach, because certainly trying to bring everyone into one location is not viable. In addition to the transportation consideration, there's There's just the general safety consideration. You know, people tend to not go where they don't feel safe. And so safety is also consideration in my mind regarding having trusted sources and organizations involved.
Great. Anyone else have more to add on that? Great answers. Another really interesting question from Inga, who noted that recently the leadership in SQUIM Washington came out as being a member of QAnon. How do we counter the active disinformation and conspiracy theories? How do we address these sort of active and sometimes very loud voices in our midst?
Well, I think we've done a lot, you know, to really be trusted voices. And I think, you know, we talk about vaccine hesitancy and mistrust. And I think, you know, in that conversation, what's often lost is that it's really up to the scientific community to be trustworthy and to continue to be open and transparent and provide information. And so what we've been trying to do is get that information out, you know, like in forums like this, and, you know, show people where they can go to get trusted information. And the other thing that I think is critical that Adrian and Stefan have both stated, and I just want to lift that up here, is that having trusted voices in the community equipped with accurate information is absolutely critical. So all of you on the line here are those trusted voices. So ensuring that you have accurate information that you can share in your communities, I think really goes a long way to combating some of the misinformation and the myths that are out there.
Absolutely. Oh, Allison, please.
Yeah, I just want to add to that. So Dr. Peter Hotez, who's somebody I admire a lot, who's a great advocate of vaccines, just reminded us that there's an active disinformation campaign going on about COVID vaccines. So every day people are receiving messages that are telling them untruths about the vaccine. So to some extent for public health, we have to kind of up our game and make sure that we're out there sending out our messages so that people are not just seeing a steady stream of one type of message and not getting the other messages. And so hopefully some of the things that are happening at this workshop will enable you to be one of those people sending out a good stream of messages. And then finally, with my patients, I always remind them, you know, did you get that from a medical source? Was that person a doctor? I try to enable people to reflect, maybe not criticizing the source directly, but just asking them, you know, what do you know about that person? Are they really an expert in this area? Is that good information? What other kind of information would help you make a good decision? So I think to an extent, I don't want to take the people out there spreading rumors, I don't want to take them too seriously, but I also have to help patients think about it in a reflective way.
Yeah.
And so I'm so glad you brought that up, Allison, because I also wanted to point to the fact that Sally and Michael have been really great at creating social media content. So we've been trying to get people to follow us on Facebook, follow us on Instagram, follow us on Twitter, because we're trying to get the content out there, and then you can just share it or forward it or whatever you do on your social media platforms. And I think, you know, because for me, I'll speak for myself, it's hard for me to come up with social media content. So it's nice when it's fed to me and I can just send it out. And they've done a really good job of that.
Absolutely, the power of the retweet. And I was going to add to Allison's point about, you know, looking at who the source of the information is. I encourage people to read past the headline. That remembering that headlines are you know, to borrow the language from my younger friends, they're clickbait, right? They're designed to get you to click on the story, but they're not necessarily the truth. And they're just the sort of sensational sort of thing that's meant to grab your attention. You have to remember to actually read down, look at the nuances, look at the details, and don't just take what was in bold print at the top as fact, because it's often just designed to get you sort of hooked and to catch your eye. Thank you, Sally. She just put the links to our social pages in the chat so that you can easily find us on Facebook, Instagram, and Twitter. Sally, maybe you could add the YouTube link as well if you're able.
Yeah, great. I'm happy to. And just the other thing I was going to say is, in creating our social content, we try to just ask ourselves, is this as understandable and relatable as a conspiracy theory? Have we that's who we're competing with. So is our content as understandable? Because I do think often that's when the conspiracy theories kind of win. It's like, well, that seems more reasonable and I can't understand this super sciencey thing. So something to keep in mind as a guide.
Absolutely. And I think the reason that I mentioned the YouTube site is because one of the things that Dr. Wallace's team has been really busy with is a variety of webinar series that speak to different communities. We've had several different presentations under the banner of COVID in Black, another set of lectures around faith communities, another set around Hispanic communities, and our YouTube page has all of those archived, so you can go back and watch that content anytime. And I noticed one of the questions I wanted to turn to from Marjorie was about what about people who are not necessarily have such easy facility with online platforms, and sometimes that can be something that you can help someone else to access. So, you may be able to, if you have an older family member that you're, living with you or in your bubble of your family, or that sort of thing, that might be the webinar that you can pull up on a computer and watch with them, so that they, perhaps might not have come across it on their own, but you could help them to find that information. I'm curious if any of the panelists have other suggestions for folks that, particularly the older adults and people that have different sorts of disabilities. What are your suggestions for helping them access information if they have, whether it's a lack of internet access, they need things in large print, they are not able to wait in long lines. How do you suggest that we best serve these individuals?
I believe, I don't have it here. I'm looking at it as I'm looking for it as we're talking, but I know that Seattle King County Public Health was setting up some access points for older adults. And if I can find it, I will put it in the chat.
Okay. I was going to point out as well that, Sally highlighted these various infographics and materials that we have available. Even though they're posted online, they don't have to live online. And you would be more than welcome to take those infographics and print them out as posters, or take that JPEG file and reproduce it in some other format that would better serve the audience that you're interacting with. We've put it online to make it easy for you to access, but you're welcome to subsequently take that information and use it in some other format that would better serve your population.
Gail, I actually have a thought on that.
Please.
And that is, I think for us here at Urban Indian Health Institute, Seattle Indian Health Board, we have a elders program. And that is one way of us disseminating the information, going down, presenting the information, providing them the opportunity to get vaccinated. And actually a good proportion of our elders have been vaccinated. But there's community centers out there. There's other community health centers that are out there that may have a senior program. And that's an opportunity to reach out to that community and educate them and provide them that information and possibly give them an opportunity to get vaccinated.
Absolutely. I know that I've seen some stories here on our local Seattle area news about EMS workers going out to different residents, congregate living facilities and the like, where they're sort of taking the vaccine to a community of people, whether that's elders or people living with disabilities. So I'm seeing, you know, some of those kinds of, you know, really patient-focused programs as well that are rolling out around the state. And I'm sure there's lots more examples than just the ones that I've happened to stumble across.
I'm actually participating in an AARP session, I think it's next week, to actually this and what the AARP can do to better support seniors getting greater access to information and support around vaccination. So I've looped in some of our expert panels from the older adult expert panels. So I'm happy to report back after we learn more about what they're planning.
Terrific. There was a question from Ellen that Michelle responded to in the chat, but I just want to share it aloud for extra emphasis. And it's this question of, we seem to have, you know, this backlog of, you know, lots of people who want vaccine, but not enough doses to go around. And I really want to emphasize, Dr. Corey mentioned this in his opening remarks just briefly, but we're kind of victims of our own success here, because we thought that the studies were going to take 7 months to get us an answer. And instead we had an answer in about 4 months, which means that, you know, we knew that we weren't going to have enough doses right away. And that only got compounded when we got an answer faster, because the manufacturing takes the time that it takes. You know, people don't often stop to think about the fact that, you know, it's not just manufacturing the liquid that goes in the vial, but it's making the glass vials, and it's making the little special rubber stopper lids that you can poke the syringe through to withdraw a dose, and the, you know, the manufacture of the vaccine itself, and then all of the testing that's done to ensure that it meets the safety standards and it's sterile and it's stable. So, you know, there are steps in the process that unfortunately cannot be done more quickly. And we are now experiencing that firsthand. I can recall Dr. Corey months ago saying, you know, there's over 370 million people in the United States. And we're talking about the government bought 20 million doses from this company and 30 million doses from that company. You know, we've known all along that we weren't going to have enough, but now we're really facing that head on. And so it's hard to be patient when you know that there's this effective product that exists, and it makes it all that more enticing. Michelle, I see that you found that toll-free number for the Washington State COVID call center. So she's put that toll-free phone number in the chat for us. Thank you very much. We've got a little over 15 minutes remaining, and as far as I can tell, we have gone through all of the questions that have been in the chat so far. So if you've been thinking of a question that you've just been, you know, dying to ask, but you haven't written it yet, here's your chance. The floor is yours. I want to encourage anyone who's been stewing on an idea that now is your chance. Or do any of our panelists, are there things that you want to add? Oh, let's see what just came in. Oh, this is an excellent question. So what are the implications of promoting the vaccine in spaces where patients may not be able to get it for some months yet? How do we position those messages?
One, I think it's about readiness, right? Because as we mentioned before, everyone is at a different place. I like the graph that Sally showed that sort of showed where people are in different places and sort of the percentages. And so, you know, part of this is about recognizing that some people are ready. And so getting those people more ready, and then also helping to get people ready who aren't ready. And this isn't, as we said, a convincing thing. This is more of an information sharing piece and empowering communities to make informed decisions. I always love seeing the little ones. So I would just add that I think it's about really preparing our communities, and to me, there's not an opportunity to do that, far enough in advance. Like the more notice, the more preparation we can give to communities, I think the greater the readiness and receptivity will be when people are able to get, vaccinated.
Absolutely. It's a great approach. Allison, please.
Yeah, and I just want to add that we're not the only ones in this situation. The entire world doesn't have any access to these vaccines at all. And so we're dining at the banquet, and there are lots of people who don't have any food on their table when it comes to COVID vaccines. So it's been such a humbling process to be so fortunate in this country where we actually are going to see them in the next few months. So I think we can walk that fine line of encouraging enthusiasm when it's available, but also helping people to be patient and to know that it is coming and their time will come.
Yeah, and I would add to that. I've heard, people say, well, which vaccine should I get, right? And my answer is always the best vaccine is the one that you can get. So whichever one is offered to you, that's the one to choose. Dr. Engman, I saw you wave, please.
Yeah, I just wanted to sort of follow on from what Dr. Oxby said about the fact that, and I loved your expression that we're dining at a banquet, because, I spend most of my, outside of the hospital, I spend most of my time in low and middle income countries or working with low and middle income countries on a variety of things. And this COVID pandemic has really been an issue, of course, right? And to be on conversations, at least 4 or 5 hours on different calls across the globe, where for many of the low and middle income countries we're privileged to partner with, the notion of even having a vaccine is not even on people's radar. I mean, they want it, they would love to have it. There are institutions around this, COVAX and the WHO and various other organizations, PATH included, trying to sort of talk about this sort of global equity. But as it was said at the very beginning, there are so many, 7 billion people on the planet, and it takes time to get to this stage. And for us to recognize that not only are we at this incredibly fortunate situation. Yesterday, as an example, I was standing in line to get my second shot, right? Because I work in the ICU, and so I'm at high risk of getting this. And this lady who was in her 70s was in front of me, and she says she was so excited to be getting this, not because she was thinking about being safe, but she said it's because my vacation that she didn't have last year abroad, she was now going to be able to have that vacation. And when I said, oh, where are you thinking of going? She was thinking of going to a country, I shan't mention the name, where I know for a fact that I'm going to be having vaccines for a while. So I started thinking to myself, wow, here we are at a situation where she's blessed enough to be in this first wave, if you like, at least globally. But as Dr. Oxby said, we don't know the impact of whether we're going to actually minimize transmissibility. We have mutations going on. And so for someone's main focus to be on trying to go on a vacation in another country where this wasn't around was troubling to me. And it started a nice little conversation. But again, I think there's a certain, I think there's the flip side of getting the vaccine, and that's the point I'm trying to get to, is that we have a responsibility. And once we have that vaccine, it doesn't mean that everything stops and we're back to normal, which is what I keep hearing. We're back to normal, and that isn't the case. We've still got to socially distance. We've still got to keep our masks on, and we've still got to be very, very careful, because as we all know this is a new virus, and we just haven't had a whole lot of experience around it.
Absolutely. Absolutely. Had a really interesting question from Jennifer, and I admit that this is not something I have given much thought to. So I'm curious to hear our panelists' responses. She asked, when talking to youth who don't have full control over their ability to get a vaccine, or who have family members that might be hesitant, how can we help young people feel like they have the power to ask questions and share what they know or what they're feeling? Please, Dr. Engman.
Maybe I can kick this off because I am a pediatrician. You know, I think most of us will agree, and any of us who have kids will agree, that when you actually take the time to listen to kids, there's a nice saying, kids say the darndest things. I actually think it's kids say the most thoughtful things. And part of what we need to be doing more of, I think, in our practices, in our engagements, whatever the situation is listening actively. And once we listen actively and we actually understand where they're coming from, that in and of itself is incredibly empowering.
Yeah, I do too. Others? This is one of those moments where I struggle as a single person and not having children to speak to in my own household. I know that I've had some conversations about this with my 20-year-old nephew, who's a science student, but he has various vaccine supportive family members, so I'm not sure he's the best example. And
I would say kids love to be independent from their family. So the job for us is to make sure that when they go out looking for information, that they find youth-friendly information that speaks to them, so that when they want to make up their own decisions in their own mind, that they'll have access to the kind of information that will work for them. That would be my approach to that.
Yeah. And Adrian, I wonder if you're able to elaborate at all. You mentioned the importance of, respecting the traditions around honoring elders. How does that sort of work in reverse? How do we empower the young people in our tribal communities?
It's interesting. I'm thinking about this, and I think one of the things Dr. Engman talked about it, and that's about empowerment of youth. And providing them the resources that they need to understand about this virus and what it means to be vaccinated. We ended up developing resources that were specific to youth. I believe it's like 9 to 18 or something like that. And it was amazing. It was really good to see the uptake on that and the interest in learning about this. And I think that might be also an opportunity or an avenue in order to get, that information out to their family, to elders or seniors, and help promote, getting vaccinated as well. That has been one of our more successful resources, is that information for our youth. So I think that's, again, like trying to empowering them so that they know about it, and that they're not afraid of asking questions with regards to what may or may not happen on this. So
yeah, great. I asked Michael if he would be so kind as to get the slide ready to show again, that has all of our social media links, our website link, the Dropbox link. We want to make sure that that all of you have, again, access to these materials. The Dropbox with the tiny URL at the top of the screen, our website, preventcovid.org, and our various social media outlets. Really want to encourage all of you to check out the materials that are there. Follow us online. If you haven't been to the website, please do take a look, and lots of great information there, and we're continuing to add to it and and evolve it over time as our information changes and we have new resources to make available. I want to, as I haven't seen any new questions come in. We've got a few minutes left, so I'll just put out one final call for questions. But I really want to thank all of our panelists for making the time today and sharing with us. It's great to hear from these different perspectives and different expertise. And thank our audience as well for really giving us some thought-provoking questions and sparking some great discussion, because our audience has raised some issues today that I hadn't thought of before, and I've been buried in this work for the past 10 months. So it's nice to be taken to some new directions and stretch a little based on the questions that we received. We just got a late breaking question from Eric. Anyone want to share feelings about when we have so little information about pregnant women from our clinical trials, and I should say pregnant persons because we don't necessarily know their gender identity. We don't have much clinical trial data. How are you feeling about the guidance that pregnant persons should feel confident to go ahead and get vaccinated? Please, Dr. Engman.
Yeah, I have a view on this because I've been quite interested and involved in some maternal immunization work. And some of you might know that particularly came to a head around the Ebola conversation, right? Because again, if you think about it in a different framing, you can wait for a trial and you can wait for all the information and then have the vaccine if you're pregnant. Or in the case of Ebola, for example, where the case fatality was so high, you can die. And it's almost like a no-brainer, right? If you look at it in that sense, if you're pregnant, is it death, a very high risk of death, or is there a strong likelihood or some likelihood or some possibility you might live and your fetus might live as well? And so I actually think this is almost like a moral question, and it's almost maybe even the other way around. I flip it the other way around in some regards, where I say, what should my feelings be about pregnant women who don't get a vaccine? Because actually that's the issue, especially when you're dealing with something where, as Dr. Andrasek talked about, the risk benefit can be quite problematic, right? And we do know that if you happen to get COVID and you're pregnant, the outcomes can be quite severe. There have been some recent studies about that. So I think that it's certainly a conversation, an ethical conversation that needs to continue. My own feeling is in situations where the risk benefit is considerably higher, pregnant women should have this. There's a lot of healthcare responders. There are a lot of frontline workers. There are a lot of folk who are pregnant, and it almost seems to me like, why should we discount them because of the pregnancy? Pregnancy isn't a disease, is it really? So I'm all for it, but again, I recognize that there are other views around. Over.
Thank you. It's a great framing. Sometimes turning the question on its head is the best way to tackle it.
Yeah.
Indeed. An attendee who prefers to remain anonymous pointed out that the WHO recently said that pregnant women should not be vaccinated. And it seems like some of their recommendations have been very mixed in the past year, and seems like sometimes they contradict some of the national or institutional recommendations. How should we view this? How should we think about this? Any thoughts? Please.
So we spend a lot of time working with the WHO, and I spend a lot of time on various panels there. I think that everyone there would probably agree that there's our normative guidelines, and that the bottom line is that countries and folks should interpret this within the context in which they're in. So they're not rules that have to be responded, but they're guidelines, and they're only based on the data that they have available. because for them, they have to also often work on data that's available. That's a limitation. So sometimes I think they get sometimes a little unfortunately panned because they may get through there may be a whole process, which sometimes can take quite a while. They come to a particular view, and then a year later or a few months later, there's a whole lot of new data that comes out, and then that view has to change, and well, the process has to go on, and then the view has to change. So I think 2 takeaway points for me are: one, local context, country context is the most important thing, and these are guidelines. And then two, really important to understand that they have to work based on normative data, which means the data actually has to be there. And that data is moving very, very fast in the case of COVID.
Excellent framing. Thank you for that. And we have an anonymous attendee who will get the last question of the afternoon. What are the chances that people in workplaces all around the country can return to their offices this year? Anybody want to tackle this one?
There are so many moving parts that depends on. The vaccine rollout, if we identify anything with the variants, I mean, there are just so many, unknowns. Hopefully sooner than later is what I'm hoping for, but preparing for later at the same time.
Please, Dr. Engman.
I might just flip this around to the person who asked the question and ask, are you sure that your offices want to be open even if there was a vaccine there? Because there's so many conversations on the other side as to saying, should we be imagining a different kind of world? We've managed so far for a year, or maybe a year and a half by the time all the vaccines are there, or 2 years. So the question is, do we go back to our offices, or do we have a different construct? And so that's the other question for me. There isn't an answer, but it's more of a question there.
Yeah, I agree. I think, it's been a changing conversation that we've, for so long, the question was, whether employers could trust their employees to work from home, and would they really get the job done, or would they be, taking time to do other things in their homes? And I think instead what we've proven is that people can be very effective working from home. So do we have to reconsider the equation? And Allison, I'll give you the final word.
Yeah, so I just want to come at this from the viewpoint of someone who studies infections and contagious diseases, which humanity has had for thousands of years. And the classical teaching on these is that when we have a contagious infection, it's vaccination that ends the pandemic and brings us back to normal. So I think everyone should leave this talk feeling very hopeful, because we do have 2 great vaccines. We have some more on the way, and history has shown us that that's how we get out of this kind of mess that we're in. So I'm very hopeful for the future. I can't say exactly about workplace or school or any of those things, but we are on the right track.
What a perfect note to wrap up on. Thank you, Allison, and thank you to all of our panelists. To our audience, thank you for joining us today. Please let your friends know that we're going to be repeating this again on February 4th. They'll have another opportunity with a different set of panelists, but the same kind of content. And we hope that we'll have a great crowd that day as well. Thank you all so much. Have a good evening and take good care of yourselves. Be safe out there. Bye-bye.